Okay, so our next lecture content is going to be on cardiac rehab. And I'm going to go ahead and share my PowerPoint. We're primarily going to be in the O'Sullivan textbook, but as well as the Score Builders textbook. So just a little bit about cardiac rehab in general. So really it's going to differ from patient to patient, and there's going to be several different pathologies that I want you to relook over from PTA 160. So anything to do with the cardiac system, any kind of different cardiac pathology or cardiopulmonary pathology, make for sure that you're reviewing those from our past textbooks in 160 as well as 150 as far as the cardiac anatomy, and Score Builders, any of that related to cardiac rehab that we haven't already discussed already for like the ECG and EKG. So but cardiac rehab in general, these are going to be patients that you're going to see typically from the acute care setting all the way to an outpatient setting. And, for example, like if you have a patient like with heart failure, these patients typically will have a higher resting heart rate. Maybe they have increased weight gain. Also, they could have worsening lung sounds and increased shortness of breath. So with these types of patients, like this example, we're going to be modifying their treatment session. Is going to be a lot lighter compared to somewhat healthy individual that we typically see. So cardiac rehabilitation in general is just a comprehensive exercise, education, and lifestyle modification program to improve and optimally their physical and psychological, social, and vocational functioning. So treatment is going to be very geared to symptoms like their vital signs, how they tolerate progressions, and utilizing like what's called RPE, also the angina scale or angina scale, improve extra, and so that way we can improve their capacity and tolerance as well, and improve their quality of life. There's a lot of things that's pretty redundant, I feel like, at the very beginning, but just all in all, we're going to look at here's the next PowerPoint slide here of the different professionals that are involved. Physicians, dietitians, they're going to be the ones like to help with their nutritional modifications and improving their eating habits. So that way, hopefully they can improve their heart health and not have other symptoms later on, especially like for prevention as well, where any kind of cardiac prevention, there's several different information. We'll look over that as well. A nurse, or nurses are also involved, a physical therapist, exercise physiologists. A lot of times you'll see them in the outpatient cardiac rehab setting as well as nursing. And we'll talk more about that, what that looks like. Occupational therapists, psychologists, and social workers. So there's several different people involved throughout the whole course of treatment, really. Now, the main goals for cardiac rehab is to maintain or improve the patient's functional capacity and their quality of life, and to prevent these recurrent cardiac events from occurring. There are, some different types of patients that are appropriate for cardiac rehab. Like if someone recently had an MI, a myocardial infarction, angina, being stable angina, a cabbage, a cardiac symptoms, high risk for CAD, end-stage renal disease, if there's status post-pacemaker insertion, peripheral or vascular disease, and a heart transplant. So any of them can fall underneath this cardiac rehab. If the ones that would not be appropriate and they would be contraindicated to be performing in cardiac rehab is if they had uncontrolled arrhythmias, a recent embolism, resting diastolic of 110 millimeters of mercury, or resting systolic, which I don't know why I didn't put that ahead of time, but anyone over 200 of 110, or maybe they have a 200 and a lower diastolic, no matter what, they would be still contraindicated, or vice versa. If their diastolic's 110 and if their systolic was 120, they would still not be indicated to perform. If they have acute infection or unstable angina as well. So there's 3 different techniques that are used to prescribe and monitor exercise intensity, and you're going to need to know all of these, and we're going to talk about each one. But target heart rate, or THR, VO2 is the maximal oxygen consumption, and RPE is a ratings of perceived exertion scale. Now, the target heart rate, so this defines for safety guidelines for exercise intensity, and so that way we know how to target their heart rate effectively. So especially for appropriate use is during endurance training. This is the Carbonin formula for the heart rate reserve that I do need you to know, because that will be on the exam. But for this for this example, you first would calculate the heart rate max, which is just 220 minus their age. So you can play around with this formula actually if you want to go ahead and do 220 minus your own age. And then you're going to input that into the Carbonin formula. So what that value of the heart rate max that you receive, you're going to subtract that from your resting heart rate. So you can just come up with one. But, in real life, you would be getting the patient's current heart rate rest. And then once you subtract those two, then you're going to multiply it by 0.4 or 40% and 0.85 or 85% in that. And then you're going to add in that heart rate rest. And that's what's going to give you that target heart rate. So you can calculate the 40% separately from the 85%. So that way it can give you a good range in between of what is going to be safe for that heart rate to increase into. And it will, a lot of times too, the target heart rate could vary from one pathology to the other too. So the VO2 is the maximal oxygen consumption that the tissues utilize in 1 minute. And usually this is determined by like a graded exercise test, like a GXT. We're not going to get into all these specifics, but just in case you want to know, my exercise science peeps should know what I'm even talking about. I'm sure you've had this at some point or another. But, with a treadmill, there's different protocols, like the Bruce protocol. There's like a stationary bike. There's different ones that you can utilize to grade the exercise tests. It can also be used with METs, which is just metabolic equivalence. And this is the rating of energy expenditure for a given activity based on oxygen consumption. So 1 MET, which I do need you to know that, equals 3.5 milliliters of oxygen per kilogram of body weight per minute. Now, it's not a very precise mode to measure oxygen expenditure, but it is one that is definitely used that you're going to see with cardiac rehab. Here is also a chart that you can pull up for the MET expenditure chart. There's also in your textbook, which I'm just going to quickly pull up here. And you can look it up yourself, but it's going to be with the heart disease chapter, I believe, in O'Sullivan. And you should be able to find the metabolic equivalent chart. It's going to talk about intensity, endurance, occupational, recreational, and kind of gives you a good idea based upon from each one. Like, for instance, with some of these are pretty funny. Like 3 to 4 METs would be like bricklaying and plastering. I'm like, okay, can we get a little bit more specific? Well, then they have later on underneath that of cleaning windows, mopping floors. So I'm like, oh, okay, that's a better idea. Another one for a 2 to 3 METs, so going less than that, it'd be like level walking at 2 miles per hour. And a 1.5 to 2 METs is, pretty low in energy level. That could be like desk work or polishing furniture, washing clothes. So not taking a whole lot of energy to perform. And this really helps as far as knowing what is too much or not enough, and with progression as well for exercise, especially for these cardiac patients. Like, again, I can say, make sure you look over those tables. Next one is RPE, so ratings of perceived exertion. And we've already kind of utilized this method without even really talking about it with all of our exercises that we've done throughout the whole entire semester, saying, oh, how challenging is this? Okay. And I didn't want you to get too stuck on the RPE scale at the moment. I wanted you to be able to know and understand the differences of when it would be very good for you to use the RPE scale And anyone with cardiopulmonary pathology is going to be great to use. I try to think even with someone with MS and they fatigue pretty easily, or anyone that seems like that is really difficult. I don't want to say difficult for them to do, but maybe you can tell it doesn't take as much energy to perform those activities. This is when our PE scale is really great to use, but you can use it with any kind of condition whatsoever if you want. And not only what RPE is pretty much what is the physical sensation a person experiences during physical activity. And this could include like with increased heart rate, or if they have increased respiration or breathing rate, increased sweating and muscle fatigue. Those are all different signs as well to show how much exertion or how much physical sensation that they're also experiencing. Now, how accurate is it? It's very subjective, just like the pain rating scale. And it doesn't give you a fairly great estimate of the actual heart rate during physical activity. So that's why I think it's better just to go ahead and calculate heart rate yourself. Now, this is the kind of like the old RPE, the Borg scale. It's from 6 to 20. So you could, describe to your patient, on a scale of 6 to 20, which is pretty big, right? I like to just use the words on the side and show them the scale of perceived exertion. So you could say, is this somewhat hard and challenging? That would be a 13. Is this very hard for you to do? Would be a 17. And 20 would be like maximal exertion. Here's the newer scale, and I have another one too, but it's known as the modified RPE, much more easily be able to describe of a 1 to 10. 1 being very light activity, such as sleep more, but more than sleeping or watching TV. 2 to 3 is light activity, feels like you can maintain for hours, easy to breathe and carry on a conversation. Moderate activity would be like a 4 to 6 level. Maybe they're breathing more heavily, but they can still hold a short conversation, but still somewhat uncomfortable, or still somewhat comfortable. I'm sorry, but it's noticeably more challenging for them to do. A 7 to 8 would be vigorous activity, borderline uncomfortable, shorter breath, but can still speak a sentence. 9 is very hard activity, very difficult to maintain exercise intensity, can barely breathe and speak only a few words. And 10 is that maximal effort activity, feels almost impossible to keep going, to where they could be completely out of breath and unable to talk and cannot maintain for more than a very short time. And here's just a comparison between the Borg and the modified RPE together, which I kind of really like because it also shows you the percentage of a max heart rate. So 50 to 60% of your max heart rate should line up with those other the Borg and modified RPE. And it goes on and on, so if you're within, if you're doing their target heart rate or their maximal heart rate, maximal heart rate is going to be 220 minus their age, and getting 60 to 70% of that, but using that Carbone formula as well, you could do. So with the Borg RPE, you can take that number and multiply it by 10, and that gives you appropriate heart rate at the time. So like, for instance, if you did, I was going to say a 5, but if you did 10, a Borg at 10, and then you multiply that by 10, that gave you like 100, right? But obviously make for sure you check the heart to see if it correlates with the RPE. I'm going to kind of move on. And the angina or angina pain scale, this is to describe the angina pectoris and how they are feeling and how it's classed. So, a class 1 would be like to where with ordinary physical activity does not cause angina, such as walking or climbing stairs, but that angina occurs with strenuous or rapid or prolonged exertion at work or recreation. So you can look at each one of these and make for sure you know the differences between each one, because then that's how you would document what class that they would be. We're going to go ahead and start talking about the cardiac rehab phases. So there's, depending on the source, This is just one that's described in your textbook that we're just going to go along with. There's other resources out there as well, but typically there's 3 to 4 phases of cardiac rehab. Phase 1 is acute. Phase 2 is on outpatient basis, and that's immediately after being discharged from the hospital. Phase 3 is considered intermediate, and phase 4 is considered maintenance. Now, in the phase 1 or acute, sorry, I'm getting my notes here, make sure I didn't miss anything else. I don't think I did. Okay. But so for this one, when you get to perform like actual interventions with this patient is only when they're going to be medically stable. And once they are stable, then this will depend on how much that you can actually do. Sorry, I'm like way ahead of what I needed to be on here. Yes. Okay. So some different things, this is going to be an acute care hospital setting, and interventions are going to be based upon hemodynamic responses, and that just means dynamics of blood flow. And how do you assess that? Blood pressure. And as well as the other vitals as well are really good to make for sure that you focus on. You're going to be taking those vitals periodically before at rest, maybe during and after the treatment or any point in time they seem to have an increase in symptoms with the activities that you're having them do. And a lot of times, this is going to, at the initial of this cardiac rehab journey, they're going to be working on functional activities such as bed mobility, transfers, ambulation, stair climbing, activities of daily living, but it's all within, depending on what day of where it is in the phase 1 of the cardiac rehab. Some challenges is that, we have to promote early ambulation for these patients and to where we have to quickly progress them in a short amount of time as much as possible, but they can tolerate as they are going to probably be discharged home. And it really just depends on your facility, depends on the physician, depends on the patient, if they're stable, if they have any lapses in their symptoms, and, to where it's kind of lengthened their journey of um, with that phase 1. So it really depends on the person to person, but this is just the general guideline. But typically it'll last like 3 to 5 days as this phase 1. So like I mentioned, you're going to be taking their blood pressure, the heart rate, monitor the oxygen saturation prior to treatment, and you'll continue to do this during and following the treatment. Now, active range of motion activities may be all that the patient can even tolerate initially, and you might be able to begin short ambulation that doesn't involve upper extremity involvement. So, meaning they're more than likely not going to be able to use a walker, especially or any other kind of assisted device, because that's going to probably be breaking their sternal precautions if they are on sternal precautions, which you do need to know that table too. So that's why it says no upper extremity involvement with that. Now, when do we come in specifically? We perform active range of motion activities with these patients as tolerated at a very low level of exercise. And also, we can provide patient education on their treatment session behavior modifications, like for eating and smoking. Also, initiating self-care activities like helping with their ADLs, provide an orthostatic challenge. Just means, they might be more orthostatic hypotensive, and working through those vitals and repositioning to improve those. Here. Let's see, go on to the next one. So this is just really where it's broken up in your textbook. It goes into, it's like in a chart, and I've kind of just taken that away and put it on each PowerPoint slide. So you can go back in your textbook and look through this phase 1. But day 1 is once PT is initiated, is how they're deeming as day 1, not day 1 of when their, heart procedure took place. And then, they're more than likely going to be in the critical care unit, the CCU. They could also be an intensive care unit, like an ICU, depends on the hospital. And, essentially they are on bed rest. So you're only going to be allowed to do like between that 1 to 1.5 mets. If you go back to that chart, not table, then you'll know what I'm talking about. And you can compare each value with that. But you can do active range of motion activities but no torque on extremity involved or traction on chest. So no resistance and no, to where it's going to put increased pressure at the chest. So no upper extremity involvement, especially. Low level exercises, you could work on like ankle pumps and deep breathing exercises, which we'll talk more about breathing exercises when we get into pulmonary anyways. This would be like day 2 to kind of give you an example. So 1.5 to 2 minutes now. Hopefully your patient is able to progress to this next stage of sitting to 15 to 30 minutes, 2 to 4 times a day, and just keeping an eye on that orthostatic hypotension. You can incorporate leg exercises like longer quads, ankle pumps, marching in place, like seated marches, and possibly limited room ambulation, depending on the patient and what they can tolerate and how their vitals are. By day 3, as you can see here, it's pretty quick, right? So by day 3, 2 to 2.5 minutes, ambulation up to 5 minutes, 3 to 4 times a day, and standing leg exercises could be initiated depending on how they're feeling. You can also utilize at this time the Borg scale, the RPE scale would be appropriate to use at this point in time by day 3. They might be able to independent or assisted ambulation in the room or the hall, depending on how they are doing. Another idea is you could have them sit on the edge of the bed or in the bathroom for washing, if like nursing's needing help, or OT if you're co-treating, whatever that might look like. Day 4 is going to be 2.5 to 3 minutes, and ambulation of 5 to 7 minutes, 3 to 4 times per day. And, we can be also incorporating, let's try and think what else. Yeah, pretty much what I just said. Then by day 5, they could perform 3 to 4 minutes. Ambulations 8 to 10 minutes is tolerated, and they could be independently performing this at this time. Now, arm exercises are optional, but it's really going to depend on really the physician, if it was written and advised, more than likely from the physician if they're allowed to do that. It's going to depend on the patient. Day 6, you might be able to start progressing them and working on stairs if that's needed to be required to go home. So ascending and descending stairs and patient education, and that's pretty much it on those. Now, patient outcomes. Now, this just depends on if there's no evidence of a hemodynamic compromise of the activity progression, if there's no systolic drop in blood pressure of more than 10 millimeters of mercury or an increase of 30 millimeters of mercury, if there's no heart rate increase of 12, if they're on beta blockers, or no heart rate increase, and if they don't have complaints of like dizziness or lightheadedness or angina, and perceived exertion of a 13 out of 20 on that Borg scale. Here's just an example for hemodynamic monitoring of the different levels. So on that level 1, performing heart rate and blood pressure before and after supine bed exercises, looking for the orthostatic hypotension signs and supine, even sitting on the edge of the bed. And then level 2, working on this orthostatic sign, the supine to sit and stand before you perform exercises and transfers. So that way you can see that the body is hemodynamically performing how like it should. Heart rate and blood pressure could be taken after leg exercises, or such as transferring to a chair, as well as after returning to bed. So you're really monitoring very often if you haven't noticed. And it really is when you're going to be asking your patient, how are you doing? With the RPE scale, even with ambulation, do you need to sit and take a rest break? I have a wheelchair right behind you. I have somebody falling behind you. So being prepared with all of your equipment is going to be very helpful of having, if they're allowed to use an assist device, or if it's going to be handheld assist, or making for sure you're being aware of the sternal precautions as well. So you can go through each one of those phases that I just showed you. Now, before as an HEP, they should gradually increase ambulation to 1 to 2 times a day at 20 to 30 minutes by 4 to 6 weeks. And they can change position or activity every 1 to 2 hours or so. Now, for the phase two, the outpatient, this will begin typically right after being discharged from the hospital, but they could begin 6 to 8 weeks later, depending on the physician, because they might want to allow the myocardium to heal. Now, for cardiac rehab phase two outpatient setting, usually 8 to 12 weeks and ranges from 2 to 5 times a week, but 3 times a week could be definitely more beneficial depending on how much their insurance is going to cover too. And this includes intensive monitoring of the ECGs and supervision. So, like at St. Clair, they have cardiac rehab outpatient. And I've been there for as my undergrad, and maybe some of you guys have as well through exercise science if you went to MSU. And they'll have the ECG, the leads on, more likely a 6 lead, and that monitor will be programmed up to the nurse's station to where the nurse is going to be able to watch how their heart rate or not, how their electrical impulses of the heart are reacting on that ECG. And supervision is going to involve nursing as well. It could be exercise physiologist as well during these activities. Some others too, they're still going to be communicating with physicians and nutritionists and providing, support maybe from a psychologist for physical, emotional, and psychological. Variables to be considered, definitely being aware of exercise intensity, duration, frequency, and mode. Then with, there's no evidence to support that lower extremity or upper extremity exercise, that there's not a carryover from one to the other to improve overall performance. You need to perform both upper extremity and lower extremity exercise. So example for lower extremity, all these are going to be endurance and aerobic activities. So treadmill, a lower extremity bicycle, upper extremity could be a UBE, like a upper extremity bike, and rowing machines are just some examples. There's several other pieces of equipment like a new step. They kind of have not just a treadmill, but elliptical. I'm trying to think what else you could use. So there's several different different types of equipment that you can use to improve endurance and aerobic activity. Now, just keep in mind that upper extremity training usually is not initiated until 3 to 4 weeks status post bypass or valve replacement. So that's important to know. Now, the intensity. So before beginning, you want to perform, they might have to undergo a low to moderate level exercise test. And intensity is set based upon a percentage of the heart rate max achieved on that exercise test, usually between 80 to 100%. Now, if they're deconditioned, it might be more closer to 50 to 60%, and sometimes they're monitored by that RPE scale. Now, with these patients, it's good to include a warm-up that takes about 5 to 10 minutes. And, to increase the temperature and increase efficiency of muscle contraction, also promotes venous return, prevents musculoskeletal injury, and the occurrence of ischemic ECG changes. And then after performing your exercises and activities, it's good to have a cool down that lasts about 5 to 10 minutes, preventing pooling of blood in extremities and preventing fainting as cardiac output or CO. You're with me here? Okay. It's working just fine. Okay. Now you see me, now you don't. All right, we'll see if it keeps on going. All right. Not sure why. Just decided to do that. Anyways, cool down. You want to make for sure that that'll prevent fainting as cardiac output and venous return decreases and prevents myocardial ischemia. Strength training and cardiac rehab. This is more recent development, but it's been I was there at cardiac rehab a long time ago, and they were doing resistance training, but very low weight. And a lot of times it depends on what the physician recommended. It might even say, oh, patient's allowed to do 2 to 5 pounds now. Still needs to be less than 10 pounds. So resistance, has definitely been shown to be safe and effective in the low risk cardiac patients. And I'm sure with research, it's going to change from time to time. So it's something to definitely keep up with. When does cardiac rehab end for outpatient? And that's when they can perform all of the activities well. And on a maximal exercise test by the MD may release them back to work. If they're not going back to work, then back to home, whatever that might look like. So the purpose and duration could last approximately 6 to 8 weeks, and educating them how it can improve their overall fitness and focus on their goals and looking at the PT goals and average frequency. So like I said, you're not really gonna, I don't know any PTs or PTAs that have worked in cardiac rehab outpatient, but it doesn't mean that you can't. So I'm sure you can. These are just examples too as the outpatient, and I do want you to look over that of the mode, just some different examples of others than I didn't already mention, as well as frequency and duration and components involved with that, as well as intensity of 40 to 85% of functional capacity, and corresponding to the 55 to 90% of a maximal heart rate. So like I said, make for sure you know the differences of that THR, target heart rate, the Carbonin formula, as well as RPE, the Borg, and the new modified RPE, as well as progression and resistance training. So make for sure you look over each one of those. This is criteria for modification or termination of exercise. So if they experience any of these symptoms that you see here, definitely if they have a respiratory rate of 40 breaths per minute, Mylanta, or if they have marked dyspnea or fatigue, all these things, or if they're diaphoretic or paler. So criteria for indication is kind of the opposite, right? If they have, if they're able to speak comfortably without signs of dyspnea with respiratory rate of 30 breaths per minute. So with those, you can look over that. These are exercise interventions utilized for patients with heart failure. So yeah, what do you think I'm going to say? Make sure you know this table. Read over it. Now, education for patients with heart disease, that might be activity guidelines, self-monitoring. A lot of it could be also met of how, the energy expenditures, how can you make it less energy for them to maybe do cooking or to do laundry. So having things that waist tight, things that don't, maybe taking rest breaks, all of that's going to be part of that. Modifications of their nutrition, their exercise, their lifestyle, socially, and with their overall wellness too. So counseling and how involved is their family and their patient, or say the patient's family, if they have caregivers. Also knowing, this is just some general counseling. You can look over that, dietary recommendations, and as well as medications. Now, primary prevention of coronary artery disease. So we're kind of switching roles a little bit here, but not really. But you do need to know that. So this is just in general for all healthy individuals that don't have a previous, um, heart disease or coronary artery disease. If they perform 70 to 85% of a heart rate max, this is the target aerobic training zone that they should incorporate, and this should be for 30 to 40 minutes, the aerobic training zone, with a warm-up of 5 to 10 minutes and a minimum of 3 to 4 times per week. So make sure you know that as well. Cardiovascular responses to exercise, acute and chronic. You can look over those different symptoms for that. Aging of the cardiovascular system, you'll have left ventricular wall hypertrophy, increased vascular thickness, reduced rate of ventricular filling, and decreased cardiac output and maximal oxygen uptake for that VO2 max, reduced exercise tolerance, decreased maximal heart rate, and reduced stroke volume. So in general, as you age, no matter what, they're going to have these signs and symptoms, and it's going to vary from person to person. But just keep in mind, for no matter what of the stages, you're really monitoring these individuals and progressing them as they can tolerate and within the time frames of the protocol maybe that you're using, as well as what the physician says is okay or not to do. Some other things besides just sternal precautions or and not using upper extremity involvement. Well, let's say upper extremity involvement, being aware of even doing bed mobility. They won't be able to reach over and grab that bed rail. They won't be able to do, um, especially in the phase one, because they would be maybe lifting more than 10 pounds because of the body weight. Now, the really high dollar hospital beds that just go from a supine to a sitting position are actually really nice. Oh, sorry. Are really nice because that way you don't even have to worry about having to lay them over sideline and getting them up. And it's a lot less stress on them a lot of times too. Trying to think what else that's important to know. Just monitoring them and having them do rest breaks and paying attention with that RPE scale, as well as if they're having chest pain with the angina scale. And there's also that Borg dyspnea scale. Make sure you look over that. So there's several different scales and outcome measures that you can utilize to see how to incorporate exercise from one patient to the other. Um, and also educating them on modifiable, non-modifiable risk factors. Make sure you look over that in your textbook of what that would look like. And, especially for like improving physical activity and nutrition, smoking cessation, all that's going to really improve them as well. So I believe that is all I have for today. You guys have a wonderful day. Thank you.